Okay, I call this facial pain management in a general dental practice. And people will come in, you've seen this slide a lot. I show this slide a lot because this is how they come in when they're in pain. They'll come in holding the side of their face, and you're going to ask yourself, is it tooth, muscle, or joint? Always assume tooth. Make sure you really eliminate tooth before you get into other areas. And so you're going to do your exam. Don't forget the exam. Be a detective, ask a lot of questions, do your provocation test, and check for maximum openings, deviations, deflections. So now you kind of have data in your mind on what might be going on, but you've already eliminated tooth. Okay? You load test, and they'll come in, it'll either be an acute pain or it'll be a chronic pain. An acute pain they're going to come in for. They're going to walk in with an acute pain. A chronic pain you got to find. They won't come in with a chronic problem. Okay? Acute pain, they're going to come in and it's going to be around their ear. They're going to touch around their ear most often, or maybe a specific muscle, or maybe the joint, but that's what they're going to look like. They're going to be holding the side of their face. They're going to say it's way over here. It'll be kind of in the area. And really what they're kind of doing is they're holding their TMJ and their masseter. Okay? What causes it? Trauma. Could be from the dental appointment, overextension, protective muscle splinting, those types of things. It could be a car wreck, could have got slugged in the face. Trauma can cause an acute pain in a muscle. That's the point. Could be any of the things we talked about last week that cause acute pain. Or maybe you don't know, or what it most likely is this one. They have a parafunctional habit. It might not have extensive wear, but they have a parafunctional habit of some sort, and they worked that muscle pretty hard over the night, and they got their muscle sore, and they turned a myofascial pain into an acute myalgia. Did you follow that? So they come in, have an acute pain, and I showed you this slide 2 weeks ago, I think, and just remember, these people take time. It is difficult at times to determine the beginning of a periapical abscess on a tooth. Often it starts obscure, it's tricky to locate. They'll talk about a general area, they won't know it's a tooth yet. And most times it could be a tooth. And these people take time, so don't just jump fast to muscle or joint. Take your time. Learn how to make a good diagnosis on beginning issues with a periapical tooth. Okay? All right. Also, take a lot of notes, because I had my record subpoenaed 30 times by attorneys. Have I told you this story? Okay. And it only ever happened with people that I was treating with TMD problems that I made splints for. And it only happened because they then got in a car wreck. And when you get in a car wreck, you get a whiplash, and they go to an attorney, and the attorney's going to ask them two questions. First one is, how's your back? Then, how's your jaw joint? And so then they want your records. They want to look at your records. Of course, then both sides get your records, and they want to see if they have any kind of case for trauma-induced TMD to make money in a lawsuit. So you don't want people looking at your records, particularly people that want to sue people. So make good notes. Make sure you're covered. Take the time that it takes, or don't make splints. All right. Short term. If they have acute pain, then you want to think short term. You want to get around their short term problem. And so often you're just treating the symptoms. So you think of what the problem is and you relieve it that way. Maybe you give them anti-inflammatories. A common regime is an ibuprofen 800 milligrams 3 times a day for up to 3 weeks. You can do that. If they have a really acute problem, then you can do that. Soft diet. Tell them to take it easy. Tell them not to open wider than the pain. In other words, just immobilize it, take it easy, don't work it, fight it with anti-inflammatories. Give it time. It just often will self-resolve. It'll go away for another day, or maybe never again. Okay? Other medicines, sometimes people like to use medicines that cause the muscles to relax if they feel like they're being overworked. The key is, though, you make a diagnosis and you insure them and you give them peace of mind. Peace of mind is very valuable. People will come in with a problem and they won't know what it is. But if you explain to them, you hurt your muscle, you ground your teeth too much last night, time will heal. Just like if you twist your ankle, you take it easy, you don't force it, you let it heal, and it'll go away. And so that peace of mind has a value, and then they leave comfortable, knowing that it's going to self-resolve. Now, if, however, though, it is caused by a parafunctional overuse, and that chronically sore muscle, which had the myofascial pain before because you palpated and you knew it, and it turned into an acute painful muscle, then say that's the first time that's ever happened, then you might think, well, explain it to them, give it time. If it comes back, then come back to it. So the question becomes, at what point do you intercept and start treatment on someone that is just in that process of ending up in acute muscle pain? And it's always a judgment call. And so what I would do often is I would just explain it to them. And I would say, look, if this comes back in 3 months, then maybe we'll talk about doing something. But often, it might not ever come back again. It might have been their only episode. So you don't want to start splint therapy and treatment until you know that it has value. It costs money and time and maybe not necessary. So, but at some point, you make that decision. And if you decide to, then you'll treat them with a splint. Remember, you do not treat teeth. They're in pain with muscles. You treat splint. All right. So that's the question, is why is a splint the number one treatment of choice in muscle or joint pain management? Who can answer that? What can you do with a splint? Real simply, deactivate the muscles. You can put them in a perfected occlusion. You can let that condyle seat. You can make it so that there's even and simultaneous contact when they close an MI, and you can make it so as soon as they go in any excursion movements, they have no posterior rubbing teeth. You can deactivate the muscles. So you can manage the forces and muscle deactivation. That's why it's the number one choice, because it's almost always a muscle. If it's a joint problem too, it will have a muscle component, and it will make it feel better. Still might have a disc problem, the joint problem, but you've helped the muscles, and the muscles will calm down and get better. So it's almost always the number one treatment of choice. Okay. Chronic pain. Chronic pain occurs often and frequently and sometimes continual. Continual, think about that. Pain's often not as intense. Most often found from an incidental examination. They're not coming in the office with a chronic pain. Now, if that chronic pain turns into an acute problem, they will, like I just explained, but a chronic pain will not bring them into the office. They might not even identify that chronic pain as being abnormal. They might think that chronic pain is just what it is, and often they do. Okay? And a common manifestation of chronic pain is headaches. So that's what we're going to focus on today. Okay? Now, if you remember from video 2 or 3 or something, this is Dr. Cranham. He's going to be doing an equilibration on Raj, but then Raj went through ortho, but he introduced Raj as having headaches. And I want you to hear this again, and then we'll pick it up from there.
Let's look at one more. Look at Raj, and again, Raj is somebody who is it's a really nice-looking set of teeth. Again, post-ortho. But Raj is suffering from headaches. Doesn't have wear, doesn't have loose teeth, doesn't have teeth that are migrating. Joints seem to be nice and stable. But his temporalis muscles, the lateral pterygoid muscle, which is behind your eye, the master muscles are all very, very sore. And what we need to see is if he's got this soreness, is it related to his occlusion? And so what I want you to think about is we would do an exam. And this is sort of a summary: severe headaches in the temporal region several times a week. He's got normal range of motion. We can load his joints. But when we palpate his muscles, the medial pterygoids and the temporalis are the main ones that are extremely sore to palpation. A little bit with the masters as well, but no tooth wear, mobility, or migration. So when you think about this, what would you look for in his occlusion to see if you think increased muscle activity is his weak link? And that's what I really want to remind you that's so tricky with occlusion, is think about the different components of the masticatory system, the temporomandibular joints, the muscles, teeth. You can have increased muscle activity, and remember, for the individual patient, it's whatever the weak link is that's going to become dysfunctional. In this case, teeth were strong, apparently. They didn't have any wear or tear. His weak link was the muscles. The muscles got sore. And so what we're going to be looking for is just, is there something in the occlusion that tells us that he is a candidate for having some of these issues? You notice the distal of the left canine, how just a little teeny wear facet there and there, but nothing really to scream home about. But this is what I really want you to look at. This is his maximum intercuspation. This is how his teeth fit together in home base. And what I want you to notice is look at the canines and notice how the lower canine on both sides do not touch the upper canine. In fact, he's got a slight open bite from canine to canine. If we were to look inside his mouth and mark, he touches premolars back. But when the canines do not engage, when they're not socked in, even with a class 1 relationship, what that means is when he slides side to side, the lower canine not touching, back teeth are rubbing, and muscle activity is going to go up. Okay? And if he does that constantly, he grinds and clenches, then that creates that consistent problem where muscle activity is higher. Now, what you would do in a patient like this is make sure that doing something to the occlusion would help. So this is where bite splint therapy, putting an appliance in with an ideal occlusion to see if the headaches go away. If they do, then we know if we change this occlusion that we're going to have the same basic effect. So I think that's pretty logical to you.
You've heard that, you know that, we've covered that. Back teeth rub, muscle activity goes up, myofascial pain develops in the muscles, particularly the temporalis. You palpate, you touch, it has trigger points and it hurts. And people walk around with a chronically sore, worn out temporalis muscles, but they don't have pain themselves unless you palpate them. But then your day goes and they're right close to being painful. If this is your threshold of pain and they're right here, then that day goes and your blood pressure goes up and you throw blood in that area, and then that takes enough for that muscle to jump over that threshold, and you get these chronic repetitive temporal headaches. Now, as we go through this, at the end, if anybody has this, come up to me, and I bet you there'll be 10 of you that have this. It's that common if you investigate it. All right, so if we're going to look at this orofacial pain chart again, if this is truly an orofacial total pain chart, I don't know that it is, but you're going to see right here in the middle we have something called tension type headaches. And so what is a tension headache? A tension headache is a head pain that results from the muscle tightening of contraction in the head and the neck. Causes blood flow. All right? And one of the more common causes, this is not the only cause, one of the more common cause of tension headaches are from chronically sore, overuse, spastic muscles and mastication, from excessive muscular contraction. All right? And sometimes we call that, this is a misnomer because they are not spasms, but we call them occlusal muscle spasms. All right, so what's that? So what is the classic occlusal muscle spasm headache? It's the most common tension headache out there. How do I know that? You saw my exam sheet. For 31 years, I looked at everybody's muscle, palpated, and I answered, and I asked questions. I'm going to go over those questions with you today to help you figure out if this is what they're having. All right. First of all, there'll be little painful headaches. They won't be huge. They won't be big ones. They won't be like migraines. They'll be most often little painful headaches. They'll be in the temporal area or right behind the eye. The temporal area because the temporalis muscle has those myofascial pain chronic problems. The masseter muscle gets the acute pain. They'll come in holding here. They won't come in holding here, my experience. And so it'll be the temporal area, or they'll say it's behind the eye. Well, what's behind the eye? The internal pterygoid, or the lateral pterygoid. It's right behind the eye. Those are the classic, and they're repetitive, and they're often, and it could have been going on for years, shockingly so, and people live with them. That's your typical pattern. If you have all of this, you get yourself a very highly likelihood of this being the cause. Okay, live with them. And I ask them, do you shake your head? Does it hurt? Does it stop your day? They go, no. Okay. Often they're misdiagnosed or they're undiagnosed. Actually, they're totally undiagnosed because there's nobody out there that can diagnose them except a dentist, because medical doctors don't know about this. And I'll go through it. So I asked 6 questions. I asked the same 6 questions for 30 years. And these 6 questions help me pinpoint. See, to find these, you have to look for these. People will not come in with a chronic pain and they'll tell you, oh yeah, doc, by the way, I'm having headaches 5 times a week, right behind my eyes. I've been getting them for years. They don't ruin my day, but I have them, and can you help me? They will not do that. They'll never tell you about them. So you have to find them. You have to get it out of them. You have to investigate. So I'm going to go through the 6 questions. The first one is, do you get headaches? Okay, and they're going to say, no, not really. They'll just say that real quick. So then what you got to do is, this is where you really find them. Because you got to stay on this question for a while. Because they're not identifying these things in their head that aren't bad as a headache. They're thinking something different. And so you got to come back around 2 or 3 different ways. I just had someone in the clinic the other day, a student, and it took 4 or 5 ways to round it out to find out she's getting these things twice a week. Been having them for 10 years. So if you just say headaches, they'll say no. They're thinking migraines, they're thinking clusters, and there you'll miss all these. So you say, well, think about it a little bit. Do you ever get them? Do you ever get little headaches? And so you come around 2 or 3 times. And then they start thinking about it. Then they start identifying it. And then they can start answering your questions. So you got to probe. You got to stay on it. Little headaches is the key. But then they'll say something like this. They won't say yes. They'll say, oh, it's allergies. Oh, it's sinus. Oh, it's blah, blah. Very rarely will they say, yes, I get little headaches right behind my eyes and they're here 5 times a week. They won't say that. They'll tell you what they think causes it. So what that is that's why they have not identified them as headaches, because they've already decided that it's a sinus problem. They've already decided it's something else, and they've lived with it for 20, 30 years, believe it or not, 5 times a week, and they already have a reason for it, so they're not going to categorize it as a headache, because they've already figured something out, and what they figured out is probably wrong. Okay? All right, so next question is, how often do you get these headaches? Now, sometimes they got to think about it because they haven't identified them. You got to stay on it. But then you'll start finding things from them when you do, and many times they'll say 3 to 4 times a week. Now you're thinking, wow, you get headaches 3 to 4 times a week? Seems like a problem, doesn't it? But you have to help them walk through that. If they say 1 time a week, that's 52 a year. That's significant. Okay? They've already told you they think it's sinus. That's the biggest thing that they blame it on. So then you try to figure out, does it happen all year? You know, how often do you get them? Do you get it during allergy season? You know, you're not going to have sinus headaches all year long. They're going to focus more in times of allergy seasons. And so you're probing, you're figuring it out. Then it doesn't have to be every week, 5 times a week. Look for patterns. And they'll go with this very easily. It'll be very easy for them to say, yeah, 2 to 3 times a week. But not all the time, but mostly 2 or 3 times a week. All right? Then it's common, once you've had this conversation, when you see them in the future, then they had a chance to focus on it, and then you'll know the real truth. Oh, yeah, by the way, doc, it's not once a week, it's 4 times a week. Now that I've been thinking about it, I've identified it. Okay? So then next question. This is the best question. Please touch on your face where you think these headaches are. I want them to touch your temporalis, but I'm not going to tell them. I don't ask them if the pain's here. I want them to tell me. I want evidence that what I can do for them will result in a predictable outcome. So I'm probing and I'm trying to find out. I'm being a detective. So then I bring back up big headaches versus little headaches, because often that gets them confused. They'll start talking about migraines, and people can get migraines and little headaches too. So you have to help them see that you really care about the little headaches. And please touch in your face. And the closer that they touch here, the better the result. If they start touching further away, you got less of a chance of it being a problem. It could be, but if they touch that temporalis area, and they almost always will, they'll touch it. They'll say it's kind of in the middle between my eyes. All right? If they say it's sinus, now you have an opportunity to find out if it's sinus. You've already probed them and you've asked them if it's all year or seasonal. But it's simple. You can just take your fingers, you can push on that maxillary sinus firmly on both sides and palpate firm and ask them if it's tender or sore. If they're having a sinus issue, it's going to be tender and sore. And it'll be on one side maybe or not the other, and you'll be able to see there's a difference. If they're not, then it probably won't. Now, that you need to know how to do that anyway, because people are going to come in pain, and they're going to have a sinus issue. It's going to cause that sinus cavity to swell. It's going to drop that tooth down a little bit, that maxillary molar, and then it's going to touch the bottom tooth too hard. And you're going to get primary traumatic occlusion, and you're going to have a sore tooth, and they think it's a tooth problem, when in reality it's just a sinus problem causing that tooth to move into a temporary hyperocclusion. Okay, so push on the maxillary sinus. Watch them. You know? All right. Next question. How long you been getting these? Now, this is a shocker. You know, this is what you hear. Somebody could be 60. I say, as long as I can remember. Or they'll tell you 20, 30 years. And you're thinking, goodness, you're getting headaches 5 times a week, 20 to 30 years, you live with them? Makes you wonder, right? Ask them if they wake up in the morning. It's not critical. If they do, that's more evidence. That just shows that they were bruxing hard that night, let's say. All right, so now, next question. What do you do for them? They'll be able to hear nothing. That's common because they're not horrible. They'll just live with them. Go on with their life. Take some kind of medicine. Take a sinus medicine. Take a nap. Go to the chiropractor. They'll have some kind of thing they do for them. But often it's nothing, or they'll carry medicine. So that's the next question. Do you carry meds with you? And for women, you say, do you carry your ibuprofen in your purse for this reason? And they'll say yes. So what's that tell you? So now you know that they're expecting to have these headaches 2 or 3 times a week, and they want to make sure they got their medicine with them that's going to cure it, because they don't make it go away. And so they're kind of, it's more information. It's a chronic repetitive problem that they're aware of. Okay? So here's the kicker. 20, 30 years, 5 days a week. Don't you think they should have told their doctor? I don't know. You would think. It makes you scratch your head. So you ask them, have you told your doctor? And then you say, what did he or she do for you? And you're going to hear nothing. That's what you're going to hear most of the time. All right, so let's walk through the doctors. They're going to go, some of them have been through all these doctors, okay? Or some have been to none. So if they've been to their medical doctor, you'll say, what did you do for me? And you're going to hear that they had a CT scan done. Can't tell you how many CT scans I've heard were done that were not necessary because they were just simple occlusal muscle spasms from a back teeth that rub, easily treated by someone with that knowledge. But no, the medical doctor doesn't know about these. Nobody knows about these. The medical doctor doesn't know about them, and so they're not going to say, go to the dentist because you don't have a perfected occlusion, right? They don't know this. And so they're thinking, goodness, if you're coming in and complaining of a headache, let's make sure you don't have a brain tumor, an aneurysm, and that's fair. And so they're going to give them a CT scan, incredibly common. Or they're going to give them medicines, okay? Or they're going to do nothing, or they're going to say you're too stressful. They're not going to really resolve them, and you're going to hear that a lot. Very, very, you will not hear them say, oh yeah, he did this and now I'm better. You won't hear that. All right. Or they went to the optometrist. They think they got eye strain. You hear that a lot. The glasses help you? No. Still have the headaches. Or they'll go to a chiropractor. They'll think it's a neck issue, and they'll get themselves worked on. I'll say, does it help you? No, it didn't help me. Or they'll go to the dentist. And now you even tell their dentist. And what the dentist might do might make them a splint. But is that dentist going to make them a splint and a perfected occlusion? I told you I hardly saw that. And so if they make them a splint, but it's not done to manage the forces of those muscles, then it's not going to help them. And so then I would say, well, can I see your splint? And as soon as I could look at the splint in my hand half the time and know if it was adjusted. You could tell by the way it looks if the dentist spent the time to adjust it in the mouth. And I'm going to tell you, hardly ever do they do. And so if not, you put it in the mouth, you lay them back, you put them in central relation, you see how it comes in. And if it comes in and that condyle seats, and it has simultaneous contact, and it excludes in any kind of movement, then goodness, you think, that's a great splint. That should have cured it. But I tell you, I don't think I ever saw it. All right? They'll go into even things like colonics and homeopathy. You'll hear all kinds of stories. Now, if they've been to the neurologist, I like that, because neurologists is very helpful on the big headaches. There are things called cluster headaches, and I hope you never get those. And then there are things called migraines, which you know about, and we tell you about migraines so you can not call a migraine this. When people give you that migraine information, this isn't going to help them. That's a migraine. It's a different thing. So don't treat every headache. You're specifically looking for occlusal muscle spasms from that lateral, from that temporalis in pain, okay? So, but if they've been to the neurologist can treat those big headaches. They give them medicines, they manage them, they take care of them, and that's who they should be seeing. But the neurologist doesn't really help them with the little headaches. Now, I can't tell you again how common little headaches are that are never treated. Okay? All right. Or they'll go to the ear, nose, and throat. I love it when they go to the ear, nose, and throat. Or I love it if they come from the ear, nose, and throat. Then they'll say, well, I thought it was my ear. I went to my ear, nose, and throat, and he said my ears are okay. Now, I like that. And then the ear, nose, and throat guys learn about this. At least ours did in our town. And then they send them to you because they know something can happen in those muscles and that joint, that disc, and that muscle, and they'll send them to dentists. So if my friends, the ear, nose, and throat, saw them, then I knew it wasn't an ear problem, which eliminated one of the possibilities for me. So I didn't have to think about sending them there for that. So I loved it when the ear, nose, and throat people saw, okay? All right, so then I say, what do you think causes them? Sinus, stress? Now, stress brings it on at times, but stress in itself is an inanimate thing. Pain comes from tissue damage. Tissue damage has to occur for pain to occur, unless it's psychosomatic, and I contend that this is not psychosomatic, made up in your brain pain. This is physical damage pain. And so you can have, as I said before, that subthreshold myofascial pain that's going on, and then periods of stress can raise your blood pressure, can get you focused, and yes, those headaches can come and go, and the pain can go based on your stress at the time. You'll see it college students, you'll see it dental students, you'll see marriages, you'll see divorces. There's times that life is more difficult that can bring it on. But the problem is secondary to the muscle issues that's underneath it. Or they won't know. They think it's low blood sugar. You hear that a lot. But this is the key. They won't come in and say, oh, yeah, by the way, doctor, I'm grinding my teeth, and I know that my muscles are tired and worn out and sore. Spastic. They'll never say that, unless some dentist told them. But on their own, they don't know they do it. As bad as those teeth look, sometimes they do not know because it doesn't happen in a conscious mode. It almost always happens it's sleeping, or if it happens in the daytime, they don't know they're doing it. They haven't focused on it. They pick it up later when their awareness occurs and they find themselves, but not typically for people that walk in your office. All right. So what's the sequence? All right. Well, you make your examination, your diagnosis, and this was true for me. This was my most common pain found outside of tooth pain because I found it. I stayed on it. If I just asked that question, do you have headaches, and they said no, and I went on, I would have never seen it. I would have never found it. And so it's that common. I've made hundreds of people that have chronic repetitive headaches. You make them split and it goes away. And think about that. You know, who understands the mechanisms of force management and all this intricacies with muscle management than anybody but a dentist could, and then only those that have been exposed to it and decide to embrace this thing within how they think. And think of all the people you can help, you know, and how thankful they'll be. All right. So what do you do? Well, you make splint therapy. We'll talk about what that means in a minute. Sometimes you need an anterior deprogrammer to help you. Okay. You have a follow-up series of appointments. You just don't give them the splint. You give it to them. You see them in 3 or 4 days. You see them a week later. You're looking for consistency with that bite. Each time you put it in and you check it, you want to make sure that those dots are there. They're equal on both sides. They're all around. They're equal in intensity. You'll find often they'll come back 3 or 4 days and they won't be in on the left side. You have them on the right side. That's because that muscle's relaxing. The inflammation is subsiding. Those back teeth are hitting a little differently. So you see them on a follow-up series. The pain might disappear the first night, but you continue to see them until you get equal, consistent dots everywhere they go when you put them in centric relation. All right? Sometimes you start them full time. If that pain is intense enough and you start them on full time, you'll get a faster result because when it's not in their mouth, their teeth are back to their teeth. So they're back to the back teeth rubbing, the back teeth problem that's occurring. So sometimes you start them full time. And then in 3, 4, 5 days, a week, the pain's gone. Then you wean them off it and you put them on nighttime only. You wean them off. So then what happens is you either then, let's say you've had successful treatment and you've cured it and it's not there anymore, and you decide, oh goodness, if the teeth were just like that, like Dr. Cranham said, then you could do something to treat the occlusion to keep them that way. Sometimes you decide that you're not going to treat that occlusion for whatever reason. Maybe you're not going to do an equilibration. You don't feel comfortable with it. Maybe, you know, whatever it might be. You can manage them often by splints alone. If they sleep in them every night and you keep your eye on it. And then sometimes they'll start coming back. If they start coming back, you teach them. Then you tell them to come visit me. You look at the bite. It's changed a little bit. You do a little adjustment. Then they're good for a while. And sometimes you have to go back to it and modify it because maybe now it's only hitting on the left side and the right side. You just follow it through time. And you have occasional adjustments. That splint then will become their binky. It'll become their binky, and they can't go to sleep without the thing because they're afraid they'll have their headaches. And if they lose it or if their dog chews it up, then those headaches will start coming back. All right, anterior deprogrammer. We've talked about this, and what it does is it relieves acute pain. It is a very fast way to get those back teeth out of the way. And very, very valuable is not only as a treatment tool, but as a diagnostic tool. So if you think you can't manage finding central relation because of the muscle spasm, then you can start them on this. And it can be very dramatic. You can put that anterior program in, and that pain could be gone the first night and never come back again in their life, and they've had it for 20, 30 years, 5 times a week. That's how dramatic it can be. And it kind of shocks you. You think something so simple, you know, and it just takes away their pain. And anyway, you don't want to do it long. We talked about why, supereruption, intrusion. It's a short-term device. And then it's a diagnostic tool. Let's say that it makes it worse, which it can. If there is a dislocation and that tissue is still innervated to the posterior area, it'll make it worse. It'll help you determine if it's muscle or disc. So it's a really nice, easy way to get confidence that you're treating appropriately. If it hurts and makes it worse, then you say, take it out. Don't use it anymore. Come back, see me. It's a diagnostic tool. Or if you can't find central relation, it's an easy way to settle things down so you can. All right, so I'm going to show this to you again, just so you remember. Look at the muscles. They're spastic. They're hurting. Look at the condyle. The green lines are not lined up. Lateral pterygoid's pulling that thing down. It can't go up and release. Now there's no back teeth touching. Since there's no back teeth touching, the lateral pterygoid wants to release. It wants to let go. It does not want to stay contracted at a very short period of time, often. Then it'll just start going back, and now all of a sudden, now we're braced by bone. The disc is there, but now we're braced by bone, and that lateral pterygoid is not holding that jaw forward. That's the concept. That's the idea. All right? So, sequence. If you're going to do restorative, we'll emphasize again that you treat pain first. If they're yellow and they're in pain, or if they're red, particularly if they're in pain, you treat their pain first and don't do anything that's irreversible until you have consistent patterns of time of pain resolution. And so you make the splint, you do what you do, and then you plan your restorative, then you do your wax up, then you do your transitionals, and then you wear those transitionals for an appropriate amount of time, and then you make your restorative. The problem occurs, people get going too quick on the restorative. And so don't take from this class that if they have pain because their condyle can't see, that if you go prep a bunch of teeth in the back and the crowns and do that real quick, that you've resolved them. Because you haven't. Often these people have swelling, inflammation, and that splint needs time in order for full healing to occur before you put them into that final occlusion. And pricing. If you're making someone a parafunctional protective splint and there's not symptoms with the muscles or the disc, then you're going to make it, you're going to give it to them, that's going to be the end of it. That's a 2-appointment procedure. And so you can have a price for that. And you can have a price that you know is fair for what you're doing. If you're doing splint therapy, though, it might be 2 appointments. No, it won't be 2. It might be 5 appointments. It might be 15 appointments. You never know what you're getting into because you need to keep bringing them back in until that occlusion stays consistent on that piece of plastic. And it will. When that muscle and that joint and disc are stabilized, it'll stay. It'll stay good. But you might have to see them sometimes. And so how do you price that? All right? Think about that one. How would you charge? If you charge You're going to give them one fee, you're going to charge them per visit. Think of it like that. And if you charge per visit and their pain's gone on the second visit, but their bite isn't consistent and you want to see them 3 more times, do you think they're going to pay you $100 to come back? Probably not. To me, that's what I think would be frustrating about being a chiropractor. In the true vision of chiropractic, they claim to want to see you multiple times. And yeah, your pain might go away, but you're not cured or corrected in their view until everything's all lined up. And you got to pay $35, $89, $200 every time you go in. And I bet you that they hardly ever see final resolution of their treatment because people stop having pain. So imagine if that was your model. And that's that was your whole thought process, and you get 6 visits in, but you never get to go all the way till you're satisfied. That would be frustrating, I think. All right? So that's what can happen with this. And so what I did was I just gave a fee. I gave a fee. It was 2 or 3 times or whatever it was, more than normal. And sometimes I did well, sometimes I didn't do well. But see, I got to finish the termination. I got to go until it was done in my eyes. Now, if everything stayed stable and their pain stayed away, then great, I was successful. But there's times that it won't. And when it doesn't, there is a point that then you need to send them somewhere else. You need to then take the next step. Maybe you then need your MRI. Maybe you then need to find someone that has a different knowledge base. And so you don't know that until you follow them out until you've resolved it. And so I chose to have a flat fee because I tried the other thing and I felt like a chiropractor and I got rejected after 3 times and I never got to finish out as far as I needed to go. All right?